less than 140 or 2 or postprandial less than 120. It's up to the convenience of the patient and the doctor who's treating. Both can be done. So let's go through a few case scenarios. This particular mother is a 29-year-old software engineer. At 17 plus weeks of gestation, she came to us and she had a history of irregular cycles. So she is known diabetic on insulin. She had a history of suction and evacuation in 2023 for a miscarriage. No other significant history except the father is diabetic. So this 2023 she had a miscarriage for which she underwent suction and evacuation. For the first time, her sugars were random 227 and HbA1c 11.3 when she had that miscarriage. Remember, she is known diabetic. That means you know like how compliant she is and how difficult it must have been for her to control her sugars. She attended the pre-pregnancy counseling clinic in view of this type 1 diabetes and uncontrolled sugars. She was counseled. We as obstetricians, we always say optimize your sugars and this should be HbA1c, end of the evaluation, otherwise you will have the recurrent infections and the worsened maternal and the fetal outcomes. So she comes to us in the month of June and spontaneous conception. She was on folic acid supplementation. Her HbA1c was 8.9. So the endocrinologist review, the diet was revisited and the sugar controls have been explained and she has been on insulin. So she had the first trimester screening, which was low risk for endocarditis, and she is screened positive for preeclampsia, which we always anticipate that diabetic mothers have a higher risk of hypertensive disorders. So despite all of us, like most of the obstetricians, they put them on 75 milligram of aspirin. That is starting as a routine, but once you do the screening test and screen positive, they are increasing it to 150 milligram of aspirin. So she's on 150 milligram of aspirin. She had the second trimester scanning done and the vaccinations were taken. And there is no doubt here, right? She is on insulin and that is the preferred therapy for her. And the insulin is a standard therapy for the woman with diabetes. So a regimen of multiple injections using both intermediate acting insulin and short acting insulin alone or in combination is administered. The advantage is does not cross the placenta and regardless of the starting dosage, subsequent dosage adjustments according to the blood glucose levels at the particular times of the day has to be done. All insulins in pregnancy are category B except for the Degludec, which is labeled as category C and it has come out in ADA 2016. We always must remember this insulin physiology because in the first trimester, early pregnancy, there is enhanced sensitivity and a lower insulin need. So the risk of hypoglycemia is more. So all these women have to be educated about the episodes of hypoglycemia. 16 weeks onwards, the insulin resistance increase, total daily dose increases linearly and almost 5% per week through the week 36. And doubling of the total dose of insulin happens during compared to pre-pregnancy and increases in both basal and bolus. Bolus takes up a larger proportion. The levels usually come down in the end of the third trimester. Sometimes we talk to the women, there is a decreasing requirement of insulin. That means maybe there is a placental insufficiency. That is because of the rapidly lowering of the total dose. So insulin should be used to manage type 1 diabetes and is a preferred agent for the type 2 diabetes that is a grade B recommendation. Multiple daily injections or insulin pump technology can be used in pregnancy complicated by type 1 diabetes. This is how the peak action and how long it sustains and what is the dosing interval. The same graphic representation is here in the tabular form over here. And we have the earlier, since we have seen here the rapid acting insulins mostly, the Lispro, short acting insulin, the regular insulins, and long acting is the Detimar and intermediate acting is the NPH, which are all commonly used. So we know about the basal insulin therapy and the bolus insulin therapy. I'm not going into the details because of the time. And it can be a twice daily regime, the insulin. Initially we started 0.9 units per kg in the second trimester and 1 unit per kg in the third trimester. And total dose is 2/3 in the morning and 1/3 in the evening. Mornings is always before breakfast and 1/3 in the evening before dinner. The morning dose we can add 2/3 NPH plus 1/3 short acting insulin. Evening dose can be half NPH plus 1/2 short acting insulin doses. Lunchtime dose of rapid acting insulin may be added if there is a continued postprandial hyperglycemia. Other one is the multiple subcutaneous injections. Before meals, we use usually the short acting or rapid acting. Bedtime, we use the NPH or a long acting insulin. Check fasting blood sugar each pre and post meals. If the high fasting, then bedtime dose has to be increased. And if high post meal, then we increase the pre-meal dose. The multiple dose insulin regimes usually allow for the individualized titration of both the prandial and the basal insulin doses to achieve better preprandial and postprandial glycemic control. The Endocrine Society recommends that women with pre-gestational diabetes who have satisfactory glycemic control with insulin glargine before conception, they can continue during pregnancy. 4 times daily insulin regime improves the glycemic control and the better perinatal outcome when compared to a twice daily regime. Continuous subcutaneous insulin infusions, the catheter is placed in the subcutaneous tissue close to abdomen, which releases the basal and the bolus doses of insulin at various times of the day, even during sleep or exercise. Sometimes mothers wish to use this for about 2 weeks intermittently during their pregnancy. It is an advantage, it's a better glycemic control we get with this continuous subcutaneous insulin infusions. So coming to the next case scenario, 38-year-old, she is a resident of Hyderabad, IVF conception, 34 plus weeks of gestation, regular cycles. She had a past surgical history of hysteroscopy for primary infertility. Parents have hypertension and type 2 diabetes. She had a spontaneous pregnancy loss at 20 weeks. And she was evaluated in the interconception period. HbA1c was 6.6. She was advised about the diet and the exercise and not on any treatment. Baseline blood sugars, she had a normal first trimester and TIFA and echo, and the baseline investigations are fine. The scan at 26 weeks showed a polyhydramnios with appropriate for gestational age fetus, and then 29, 33, 35 weeks she had these fetal well-being scans. She was in Australia till the mid-trimester. In view of short cervix, she had an emergency Shirodka circulation was done there. And the sugars, she was started on metformin 500 milligram twice daily. Because of the HbA1c 6.6, she was doing co-monitoring of the blood glucose and she was started on metformin. She was under the regular follow-up with the endocrinologist. At 34 plus 6 weeks of gestation, she was admitted in preterm labor. Couple wished for a vaginal birth. The Shirodka stitch was removed under spinal anesthesia. Labor progressed spontaneously. She had intrapartum blood sugars were normal. She received Entonox for pain relief. She had assisted vaginal delivery with low forceps, 2.3 kg baby, and active management of the third stage of labor was done. So what is the role of oral hypoglycemic agents and what are the different oral hypoglycemic agents that are being used? The most commonly used is metformin. There are few research articles on glegride, and the main indications being type 2 diabetes, gestational diabetes diagnosed after 24 weeks, and history of polycystic ovarian disease syndrome where the woman was on metformin earlier, which will be continued during pregnancy. Maybe sometimes they stop at 16 weeks, they do the OGTT and again they find it abnormal and continue abnormal, then they continue without oral hypoglycemic metformin. Advantages of frequent injections of insulin can be avoided, lesser risk of hypoglycemia and a better compliance. We all know that continuation of the metformin in first trimester did not prove to be hazardous to fetus, but continuation of it in further trimesters without any glucose intolerance is not of use. In presence of glucose intolerance, efficacy of metformin is equivalent to insulin because similar glycemic control, no differences in the rate of congenital malformations and a similar rate of neonatal hypoglycemia. So the dose is 500 milligrams once or twice daily and maximum you can go up to 2 grams. The second generation sulfonylurea, glegride, there are few studies. Efficacy is equivalent to insulin. Glycemic control also was equivalent. Caesarean rates and LGA rates were comparable. Few congenital anomalies reported in either groups. So the recommended daily dose is 5 to 7.5 mg per day, total up to 20 milligrams. It should be taken 30 minutes prior to meal. Risk of interprandial hypoglycemia is there. With this 2-case scenario, insulin versus oral hypoglycemic agent, a topic which I have, what does the literature say? Both American College of Obstetrician Gynecologists and American ADA Diabetic Association, they recommend insulin as the first line of treatment. Type 1, anyway insulin. Type 2, insulin is preferred. But always it is a multidisciplinary team involvement. Now, what does the NICE guideline say? In 2020, women with diabetes may be advised to use metformin as an adjunct or alternative to insulin in the preconception period and during pregnancy, when the likely benefits from improved blood glucose control outweigh the potential harm. If metformin is contraindicated or unacceptable to the woman, offer insulin. Women with a fasting blood glucose higher than 126 with start immediate treatment with insulin. There is no role for metformin. Later, probably while on insulin, metformin to be added depending upon the blood sugar levels. ADA recommends insulin as the first line agent. Metformin can be used as an alternative in women with cost, language, comprehension or cultural barriers. These are very common in our country. Metformin is associated with lower risk of neonatal hypoglycemia with less maternal weight gain compared to insulin. Most of the women say, I am not gaining weight. We just reassure them. You are on metformin, you will not gain more weight. But after discussion of the known risk and need for more long-term safety data in offspring, metformin should not be used in women with hypertension, preeclampsia, risk of intrauterine growth restriction due to potential for growth restriction, and acidosis with metformin in the setting of placental insufficiency. ACOG says metformin can be used in women who are unable to safely administer insulin or who decline insulin. Yes, we do have such women who decline insulin. It is started after discussing with the patient about the limitation of the safety data and the high rate of treatment failure, ultimately requiring insulin. Maximum dose is of 2 gram to 2.5 gram. What does the FIGO guideline say? Insulin, glyburide and metformin are safe and effective therapies for GDM during the second and the third trimesters and may be initiated as a first line of treatment after failing to achieve glucose control with lifestyle modification. FOGSI endorses this FIGO guidelines. It has come out in 2021. Among the oral hypoglycemic drugs, metformin may be a better choice than glyburide. Insulin is considered as a first-line treatment with women with GDM diagnosed before 20 weeks. The need for pharmacological therapy after 20 weeks is when the fastings are more than 110 or 1 hour more than 140 or the pre-pregnancy weight gain is more than 12 kilos. We have this landmark trial, most of us obstetricians are well aware. This is the MIG trial in 2007. So we have this primary composite outcome measures as well as the secondary composite outcome measures. Only thing which was found in these results is there were no serious adverse events associated with the use of metformin, and the supplemental insulin was required in 46% of the women in the metformin group. So more women stated they would choose to receive metformin again, and the rates of also the secondary outcomes did not differ significantly between the two groups. What were the secondary outcomes? The neonatal anthropometric measurements, the maternal glycemic control, maternal hypertensive complications, postpartum glucose tolerance, and acceptability of the treatment. Only thing is preterm births were more in metformin, but they were spontaneous, not iatrogenic because of uncontrolled blood sugars. That was the only thing which is very less. Coming to the next article, insulin versus Origen. This is the adverse perinatal outcome in the diabetic mother treated with oral hypoglycemic agent versus insulin. Similar glycemic control and no adverse perinatal outcomes. Within glycemic control, maternal treatment with insulin showed significant difference in LGA compared to oral hypoglycemic agents, which require further studies for validation. This is another open article, access article, glycemide, metformin and insulin, a systematic review. This showed in short term in women with gestational diabetes requiring drug treatment, glycemide is clearly inferior to insulin and metformin. This is another systematic review or meta-analysis, short and long-term outcomes of metformin compared with insulin alone in pregnancy. It showed metformin lowered the risk of neonatal hypoglycemia, large for gestational age babies, and pregnancy-induced hypertension, and total maternal pregnancy weight gain. Another article, glycemic control and neonatal outcomes in women with gestational diabetes treated with glyburide, metformin or insulin. This also, the present meta-analysis suggests that metformin may be as effective as insulin for glycemic control and is the most promising drug for the prevention of neonatal and maternal complications. This is the famous TOBOGM study, hyperglycemia and early pregnancy, the treatment of working gestational diabetes mellitus. They say the early treatment is actually the intervention resulted in the risk of reducing the risk of adverse neonatal outcome, and major contributor is with respect to the first primary outcome was neonatal respiratory depression, and also exploratory subgroup analysis suggested benefit of early treatment among women with OGTT result in higher but not lower glycemic range. So finally, insulin versus oral hypoglycemic agent, I would like to conclude it should be patient-centric. The diagnosis of hyperglycemia, the gestation age at which it was diagnosed, and also taking the family and the woman into consideration, still metformin has a good promising results diagnosed after 20 weeks in gestational diabetes, and type 1 diabetes, insulin, but maybe later they may require metformin during the course of a pregnancy. Thank you, and I'm sorry for overshooting my time. Thank you.